I'm going to now just briefly introduce the panelists who will be talking with me today on particularly emphasizing the questions on screening for alpha-1 antitrypsin deficiency. So three very engaged young folks who will be participating today. The first, Monica Goldklang, is from Columbia University in New York, and she's a very active investigator in alpha-1 as well as a practitioner. Secondly, we have Igor from UCLA, who's engaged not only in alpha-1 education, but also is an intensivist and an expert in liver disease and the liver component of alpha-1 antitrypsin. And lastly, Kyle Hogarth, who is a pulmonologist, critical care specialist from the University of Chicago, where he also is very well known for his interest in alpha-1 antitrypsin and his ability to educate healthcare practitioners on this subject. First is talk to me about screening asthmatics, and then secondly, talk about the Grifols screening program.
In general, the data that we like to quote for a while is that a patient with alpha-1, diagnosed with alpha-1, on average has previously spent 7 years looking for the diagnosis and seen at least 3 physicians. And we like to kind of talk about this data. And you could argue that nowadays with the guidelines that are out there since 2003, and I think this is very relevant that I remind, it's 20 years almost, very clear that we have very clear indication to screen, that there are no insurance issues with screening, and then the also industry facilitated the screening, which gets me to what you mentioned. There are multiple industrial partners that work together along with Alpha-1 Foundation. They all work together in an organized fashion in which these kits, the simple kits, are kind of prepared, distributed to primary care, to pulmonary offices. They are very simple. They can either be the finger sticks or even buccal swabs that are doing the simple, reliable methods of screening. When I do a blood work, I screen for alpha-1 antitrypsin. And I think that the providers should be familiar that in their institutions, there might be several different tests, and the alpha-1 levels per se may not be sufficiently good for screen. They're alpha-1 phenotype or alpha-1 genotype. And if there is a blood work, these tests are readily available. If this comes just an add-on, it's a free screening. And I think that the way to really look at this is that this should be incorporated in a practice. In my COPD clinic, when subject comes to be seen, actually, this is part of the workup. And in that sense, there is no reason for me to think of who should be screened. Everybody gets screened, and then we discuss exceptions not to screen. And I think that should be the appropriate way.
Let me just ask you guys, and anybody can chime in here. What do you think about the additional alleles in the buccal swab that we're picking up? Has that been of value to you? It has been to me, because I guess I see a lot of very peculiar cases of alpha-1 just because I've been doing it for so long. And finding those other alleles and working them up have been very interesting and have led to some importance. The patients being or having their treatment alter. Has that been true of others, or is it too new? The screening with the buccal. Monica, could you?
Yeah, Jim, I can give you a great story of a patient who had a phenotype done, and she thought that she was MZ, and then she had her child genotyped, and the child came back actually as a MF. And as you know, the F allele is functionally it is not functional, but on isoelectrophoresis would look like an M. And so this patient actually had walked around, and she herself was a FC, and so is functionally like a ZZ patient. And so having something where we have a true genotype can only help us to make more diagnoses and make precise diagnoses for our patients.
Yeah, I mean, Jim, it's a genetic disease. We want to know your genetics. And so the expanded genetic capabilities of the buccal swab test that Grifols provides is a huge benefit. And if for whatever reason, for me, it's all about clinic efficiencies. If your clinic is not set up to be able to use the buccal swab for whatever reason, then fine. If you're going to be seeing this patient and drawing any amount of blood and you've made an obstructed lung disease diagnosis, tack on the alpha-1 genotype. Some labs call it a phenotype, but just order the genotype so that it's coming with your next blood draw as well. Whichever way, in the end, when you've done the test, you've done your duty as a physician to manage the disorder, the COPD that you diagnosed them with.
Sounds very good. That's very helpful. The next question, what has been the biggest value to you and your patients since you started screening COPD patients for Alpha-1? And this is first I'd like to take a shot at, because I was here doing COPD even 50 years ago. So that's how far back I go, in the early 70s. But anyway, we didn't have screening earlier on. We send a level down and what have you. But it's been tremendous, not only for the individual patient, the fact that you get really accurate information that's scientific, that you can really, because it is so accurate, hang your hat on it. And then you can use that information to expand your search to the family members and use that as a great opportunity teaching point. And as many of you made, when we did the study a few years ago under, I think it was the foundation, where we screened everyone who was obstructed in the COPD in the pulmonary function lab, 1 in 10 were carrying that gene. I think Kyle, somebody said that before, were carriers. Very few were ZZs, but a lot were carriers. That's really, really, really important. So Kyle, I'm going to ask you to follow up to that. What is the risk of not screening for COPD? What kind of damage could be done?
That's a great question, because let's just start. I think some of our colleagues have said this already. Let's just begin with the knowledge that there's a genetic predisposition for the development of liver and lung disease that runs in your family. That automatically gives you the ability, as both a clinician, to talk with your patient, but then to provide the insight to the patient as to why some lifestyle modifications immediately matter, from either smoking or career choices, and then obviously weight and alcohol intake, et cetera. So upfront, you can make changes, and they're not just oh, sure, every doctor tells me to lose weight and not smoke. I can say, no, definitively, you, not anyone else, you genetically have to do this. And here's why. Here's what's going to happen. So right up front, that information matters. But also, think about it from just put it into the mental context of any other disorder that you're not managing, and yet there it is continuing on and ravaging 2 separate organs potentially. That's why this matters so much, because it allows us to manage the disorder. We have treatment for Alpha-1, especially when it's related to the lungs. We have a bunch under development in relation to the liver. But at the same time, let's go a different step. I've diagnosed you with Alpha-1. Let's say you actually at the moment have 0 clinical manifestations other than some mild abnormal liver function tests. But now I'm about to put you on a statin. Maybe I'm going to rethink my medical approach to your other disorders, thinking up front of potential damage to your liver. I don't know, but an informed patient and an informed clinician make all the difference in regards to managing everything that we're dealing with in a primary care setting.